morning, everybody. It's my pleasure to introduce Timothy Witham, who is visiting us from Johns Hopkins. Tim is director of the Johns Hopkins Bayview Spine Program. He's professor in the Department of Neurosurgery and Orthopaedics at Hopkins. He is director of the Johns Hopkins Neurosurgery Spinal Fusion Lab.
All right.
If somebody could tell them about and associate program director for the last 10 years.
Okay.
Went to undergrad at Penn State, medical school at Hopkins, residency in Pittsburgh, then did an AO spine fellowship with Zia Gogaslan back in 2005, and has been there since. And it's our delight to welcome you, dear Tim, and tell us about augmented reality in spinal surgery.
Thanks very much for that.
I'm sorry, and those of you who are on Zoom, please, if you could mute your phones and your laptops. It is very distracting to us here in the audience. Thank you very much.
Thanks very much for the warm welcome. I'm very excited to be here. I would like to give you sort of a rundown or an update on where we stand with augmented reality and spinal surgery. Hopefully by the end of this, I'm going to convince you that this is something that is, I think, valuable in certain instances and for certain people, probably not everyone. But I do think it's going to have a place in our future work and is going to be around to stay for a while. I am conflicted. I am a surgical advisory board member of Augmented and a stockholder there, and I use their device, the X Vision. Now, I did sort of I think what a lot of people would do when they kind of wanted to learn about the University of Texas McGovern Medical School and Memorial Hermann, as I went to your website, and the first thing I noticed as a spine surgeon is I had no idea what kind of device that was at the front of your website. It looks like maybe some kind of robotic or maybe functional device, but certainly a little bit intimidating for a spine guy. I did notice that way down in the corner, it sort of looks like is this Art Day? Yeah. I was thinking, this would be great to have Art Day give me a lecture on looks like spinal anatomy. So that's really cool. And then it also kind of reminded me of Hopkins because, up here on the top bar here, ways to give. So, there's something in common with a lot of these institutions. But more seriously, this Texas medical complex is amazing. And I know that there's a lot of excitement around here, particularly with your program and Dr. Morkos and the other great leaders here in terms of, really, I think moving the program forward. And so far, what I've been able to learn is that excitement is real. I'm going to kind of go into the augmented reality stuff. The definition of augmented reality is when you take a computer-generated image and you overlay that image on your view of the real world, forming a composite or augmented view, if you will. And if you go to the FDA's website and look at augmented reality or virtual reality devices in medicine, you'll see a list, and it's a moving target, actually. There are probably at least 40 different devices that are registered for FDA approval, and about 6 of them have been approved for some kind of spinal application. And this number is growing. And like I said, it's growing pretty rapidly, interestingly. So I think it is a new technology that seems to be gaining some traction. There are a number of examples of it in neurosurgery. This is Chris Nimsky and Barbara Karl in Germany, who have used this brain lab device with an intraoperative CT, and they use computer overlay. They're able to match some of their preoperative MRI scans with the CT that they generate intraoperatively, and then so then what they can do is that data is utilized, and they have a tracker on their microscope and then on the tool they're using that's followed by this remote camera. And using this device, they've found that it's helpful to take out a number of different kinds of tumors and treat really a variety of things. And they've shown some pretty neat ways to utilize the augmented reality in that setting in spinal work. There are some other examples. This is Dr. Elmi Terender out of the Netherlands. This is an interesting device where they have a 2D, 3D fluoro machine that has a camera actually embedded inside of it. And so what they can do is they can use the camera, that's visualizing the patient on the table. And so that's the real view. And then with different instrument trackers, they can overlay, for example, placement of pedicle screws. And they've shown in cadavers and in humans a pretty high accuracy rate, I think in the 95 range, using this device. So this was also one of the first augmented reality devices used clinically. This is an interesting device. And an example of a failed technology. I don't know if anybody was involved with Surgalign, but it seemed like kind of a strange idea to me, because you have this, it's almost like a little iPod thing that goes over the operative field while you're kind of trying to navigate underneath it. And the augmented views to assist with instrumentation placement show up on that iPod, but I never had a chance to try it out or use it, but it really didn't go over too well with the surgeons who did, and the company went belly up, basically. This is another platform that utilizes preoperative planning and computer overlays to help remove tumors, surgical theater. Colleague of mine out at Stanford has used this for some sacral tumors, and it's kind of an interesting device. Another company, Medacta, which is up and coming, they haven't really gotten up running in terms of a lot of clinical cases yet, so I don't really know a lot about it, but they are proposing sort of an orthopedic ecosystem that can be used to navigate all kinds of orthopedic procedures, including spine and spinal instrumentation placement. Their spine platform is called NextAir, so that's one that's an up-and-comer. This is another one that's up-and-coming, VizAR, out of Utah. I actually have a meeting with them next week to see what their platform looks like. But they're also initially targeting the use of pedicle screw placement using this system. I did take a look at this system. This is a really cool one out of Israel. It's a company called Payonix. And I don't know if any of you have used the exoscope here. We actually bought one, and I got to tell you, it's a little bit finicky to use at first. And for people that are sort of used to using the microscope, sometimes it's a little bit tough. But there's a remote screen, and you have this exoscope that kind of sits in the middle of the field, and it gets a little bit sometimes cumbersome to actually look around, either the person opposite you, to see these screens. But what this company decided to do was take this similar concept with an exoscope and then link it to an augmented reality headset. And what they've also done is they've moved the camera higher up, so it's sort of out of your way with very similar image quality. And I think this is actually, and they also have a pedicle screw placement platform. I think this may be something that actually takes off both for cranial surgery and potentially spine surgery. So that's one to look at in the future. And this is a super new one that just came across my desk that I don't know a lot about, but this is a company called Biopac, who is introducing a wearable headset that you can have a brain-computer interface that performs AR and AI. So sounds like a lot to do, and I'm interested to see how this one pans out. So that's an example of some of the devices that exist so far. Just as an interlude here, I had a chance to, my sister got married in Kenya, kind of a destination wedding on a safari. And if anybody ever gets the chance to do that, if you ever do it, I highly recommend it. It's a real bucket list thing. We went to this Maasai area, and you can see Kenya's in East Africa, below Somalia and above Tanzania. And this kind of border between Kenya and Tanzania is a real ripe area for a lot of these safari type excursions. You can see a blow up view. It's a little bit to the west and south of Nairobi, which is their capital. And some of the things I got to see there were really quite spectacular. See if I can get any of these videos to run here. Yeah, just, I mean, you're literally feet away from some of these animals. It was just an incredible experience. So I think the thrust of most of these newer AR companies has been focused first on pedicle screw placement and trying to come up with a better way to place pedicle screws, perhaps. What I always tell our residents is the best way to place pedicle screws is the best way that works for you. And, you know, really, if you look across the literature at the different techniques, freehand, fluoroscopy, CT navigation, robotic navigation, there's a wide range of accuracy rates depending on the study. But the people that really do each individual types of pedicle screw placement well can place the pedicle screws very accurately. So I'm not here to tell you, oh, you know, augmented reality is the best way to place pedicle screws. I think for some people it may be great, but you know, I have colleagues who place freehand screws and they can do it just as accurately. The one thing I will say, I spent probably at least 15 years placing pedicle screws by freehand, and I do think that there's an advantage when you really know the anatomy and then you use some of these technologies like robotics, like augmented reality, because what happens is the machines aren't always 100% accurate. They're not foolproof. But if you really know the anatomy, you know when the technology is off. The registration could be off. Registration marker could have gotten bumped. And there could be a problem. It's really kind of recognizing that problem that I think is a real difference maker. And so for people that are just relying on the technology, if the technology fails, then you always need a plan B in the operating room. We even looked at placing pedicle screws with an intraoperative CT scanner, and there were a couple things we noticed there. One was that even when we place pedicle screws accurately, a lot of times we would try to make them perfect, and sometimes in the process of revising it, we put the pedicle screw in the wrong place. So even an intraoperative CT wasn't completely 100%. Excuse me. Well, you know, traditional navigation and robotics have the one disadvantage of having to look away at a remote computer screen, and this is called attention shift, which can negatively affect cognitive and motor tasks. Additionally, when there's a remote camera, there's often, just like in cranial navigated cases, you know, there's always a disruption of this line of sight, and it can get fairly annoying during these cases. One solution to this is having a head-mounted display with AR. And there are some early examples of this with aftermarket devices. This was Larry Lenke's group. We used the Magic Leap headset. It was not a headset specifically designed for AR for medical use, but they showed it could be used in cadavers. Similarly, the Microsoft HoloLens, this was a Swiss group, they showed it could be used well for insertion of S2 AI screws. The device that I've had the most experience with is the Augmented X Vision. And essentially what you have is you have the navigation machinery inside of this headset. So you have a camera that can track both the patient marker and the tool marker. It has the data registered from an intraoperative CT and can then project that data directly on your retina through these lenses. This is the setup for that. This is an example of an open case. They now have a percutaneous pin, so we do MIS and open cases. A registration marker is placed, and then the CT is performed, and then the data gets sent through an internet connection to the headset, and then you can navigate by tracking the tool marker and the registration marker. One of the beauties about this, it's an advantage and disadvantage. One of the beauties, again, advantage or disadvantage, is that it is vendor agnostic. So right now, if you're using Stryker, Medtronic, Globus, DePuy, you can use any of those because they're not specifically tied into a metal company yet. So that was sort of part of their original marketing scheme to do that so they could incorporate more users. This is what it looks like intraoperatively. Typically, you'll have two surgeons, each with a headset. And you're really only wearing the headset for the instrumentation part of the case. A lot of people say, well, gosh, I don't want to wear that headset the whole case. And you don't really have to. You're just doing it when you're either cannulating the screws. A lot of times I'll just cannulate holes, put the screws in later. But this is what it looks like in the middle and to the right. There's typically a 3D view and then an axial and a sagittal view that shows your real time, if you will, navigation. It's actually very hard to get the picture through the headset. You have to put like an iPhone on a headset that's looking at the field. So it's a little difficult to get that. Sorry about this, getting over a cold. This is another view of what you would see through the headset. In this case, a percutaneous case. So I was fortunately involved with the first proof of concept studies for this. We did an open cadaveric study with accuracy rates in the kind of 95 to 96 range. The FDA required a percutaneous study as well, which was done with some of my colleagues out in Chicago. And they actually had 100% accuracy rate thoracic and lumbar spine, and with both jam sheeting needles and a little less accuracy with the pedicle screws, but still similarly very high and acceptable by the FDA. This device was cleared based on these studies for FDA approval in December of 19. We were fortunate to do the first case at Hopkins in June of 2020. And published that first case. I kind of tried to line up a relatively straightforward case. It was an L4 S1 fusion with a woman with a spondy at L4-5. One of the things that I actually did during this case is normally I place my S1 screws bicortical, and I didn't do it just because I wanted to make sure the accuracy was proper and the screws were inside of the bone. We looked at accuracy and precision, and the two are a little different. And now you know, a lot of these new navigation systems are being evaluated based on precision. And so accuracy basically says you can hit the target, but precision says you can reproducibly hit the target where you want to hit the target. And so precision is now the way people are looking at a lot of these navigation systems. And so the way you measure the precision, it's a little bit complicated to do it in the operating room, actually. You have to re-register after you drop phantom pedicle screws. You have to put the registration marker back on and do another CAT scan and then compare where the screws actually ended up to where the phantom marker said the screws were going. And then you can define or devise a linear deviation and an angular deviation. And so for that first case we did, the mean linear deviation was about 2 millimeters and the angular deviation was 2.4 degrees, which compared very favorably to similar results with, let's say, a stealth station or Ovis. Again, I'm not going to say it's better than traditional nav or robotics, but nonetheless, it does seem to be effective with what you're trying to accomplish. I don't know if any of you had a chance to go to the WFNS in Cape Town, South Africa, but that's another bucket list place. This is called Lion's Head. We took an early morning hike up here, and it's next to another bigger mountain right inside of Cape Town called Table Mountain, and you get this spectacular view of the city and the ocean.
I'm glad you guys like each other. Otherwise,
yeah, I tell you, I was a little scared standing there. This is Tej Azad, one of our residents, but yeah, that was a little scary, but nonetheless fun. This was something else I saw down in Cape Town. I get this to work. It's a baboon that we saw on the side of the road.
The one sitting in a tree, madam, is a little lady. Sitting your pose there.
It's a life bracelet.
So we looked at our series of our first 205 screws with the Augmented X Vision, and using the Gershbein-Robbins grading scale, had about a 98% accuracy rate. Grade A, it's a busy slide, but grade A and B are considered accurate with this grading scale. Other groups have sort of reproduced this. This group out of Northern Virginia, Chris Good and his group. They also came up with about a 95% accuracy rate for their first 218 screws. This is a sort of a systematic meta-analysis with about a 92% accuracy rate. One of my colleagues, one of our former residents, Camilla Molina, who's now out of WashU, used this for percutaneous placement in the thoracic and lumbar spine in a relatively small series of 63 screws and had a 100% accuracy rate. And then this was probably my scariest moment on the safari here. This was one of the leaders of the prize. That was a little bit scary, I thought. That was scary. So one of the things that's been really great for the AI has been for placing, John Quinn can probably identify with this, has been placing S2 alar iliac screws. Because I think a lot of times if you try to do it freehand, you really struggle with that. You can bring in fluoro, but that's also a little bit painful wearing lead and such. But this has been a real easy way to place S2 AI screws. And this was actually a case where I did a revision of a failed L5S1 fusion, and there was a broken screw at S1, and not only was it pretty seamless to place S2 AIs, but I was able to actually place another S1 screw around the broken screw, which sometimes would be, difficult, I think, without a navigation modality. Another case I did, and we've done this on several patients now, is when there's been a failure using dual S2 AI screws. It really helps to have the view to see where you can place two of them in the same patient on the same side. And you can see the different views seen through the headset to navigate placing two of these screws. This was the final result, where we had dual S2 AIs in a woman who I had tried really hard. I think I never figured out what was wrong with her bone, but she had an ALIF and posterior fusion, and finally got her to fuse after, a revision, but required these dual screws, which I thought was helpful in this case. So we published on that in Operative Neurosurgery. There are initial series of 23 screws. We had about a 91% accuracy rate with a breach of less than 3 millimeters in one case. The breach of greater than 6 millimeters was sort of the outlier. But if you notice, the company had to make adjustments because when we originally did these screws, we couldn't see the entirety of the ilium in the field of view, as you can see in the upper right corner here, but they've subsequently made changes to the software to be able to see the entire ilium and be able to place screws that are 100 millimeters or sometimes more. But the one that was errant was done probably because we didn't see the distal part of it, and we probably breached at the very distal part. So there are a lot of sort of improvements that can be made to all of these types of technologies, and that gets done on the fly.
This video.
This was just a video that went along with that paper that one of our residents did.
Display using augmented reality for S2 alar iliac replacement. Two screens are visible, axial on the left and coronal on the right. There's an option to add a 3D display. In this view, the surgeon is using a 5/0 tap to cannulate holes for the S2 AI screws. The surgeon uses both the real-time visualization on the headset.
Like I said, it's actually tough. The company didn't come up with a way to actually video what you see through the headset. So you have to hold like an iPhone in front of the headset to get this footage. I think they're looking at another way to do it.
Members of the surgical team without headsets are able to visualize navigation on the screen as seen here.
Another unique use of this technology was when this case presented to me, and this is probably similar to some of the trauma cases you guys get around here, but I had a woman who fell off of 3 steps and landed directly on her butt on concrete. And she had underlying osteoporosis for sure. And she developed this complete spondyloptosis of the sacrum, as you can see on the left, where she basically dislocated between S1 and S2. And I had to put a little bit of thought into figuring out, exactly how I was going to try to fix this. But I decided that, you needed more than one point of distal fixation. So I decided, okay, we would do the dual S2 AIs and then attach the rods after placing screws also at L3 to S1. Lock the rods on it at the S2 AI screws, and then reduce the rest of the spine up to the rods. And you can see in the center, we were able to get a pretty reasonable reduction. And her post-operative films also looked very well. And she did pretty well after the surgery, all things considered. She had some bowel and bladder issues, which was pretty much expected with this type of injury. I will say that, you know, this would have been a very challenging case without some form of navigation or robotics, because you can see, you would imagine that, you know, the S1 pedicle entry site is like, you know, it's going to look like it's like 5 feet deep inside your incision. And to figure out, you know, visually the landmarks where that entry site is would have been very challenging in this case. And I relied heavily on the technology to capture those S1 screws. This can be used in tumor, and one of my colleagues, former colleague Dan Shuba and Camilla Molina, used the AR in this case not only to place instrumentation, but plan their osteotomy cuts to remove this L1 chordoma in an en-bloc fashion. Trauma is also something. Percutaneous stabilization was done in this case, where the guy basically had complete destruction via a gunshot wound of his left L4-5 facet. And so I felt like this was a nice way to stabilize this patient with a percutaneous approach in placement of pedicle screw instrumentation. But it certainly is great for other trauma cases. I love it for ankylosing spondylitis cases. It can be done percutaneously with, you know, a lot lower blood loss, and where you're not as concerned about the fusion. And it's been really good for resident education as well. I think that the sort of generation of residents right now is such that they're very fast at picking up this type of technology. I think some of that has to do with kind of the gaming mentality. A lot of the residents and students of kind of this era are used to the gaming stuff, and so they pick up this extremely quickly in the operating room. This video got kind of sabotaged, so let's skip over that. Like any other new technology, it's not without limitations, and there are potential pitfalls and failures that can occur. We've had situations where we had to abort cases because the software wasn't working for one reason or another, technical reasons. Sometimes patients we've had several patients that are too big and we haven't been able to get the registration done. For the most part, that'd have to be a pretty extreme case. And then, like with other navigation, if you disrupt that clamp, then it's a real problem, because then you either have to go through all the steps to re-register or just go to plan B with freehand or fluoro or something else. The current status of this device is that you do have to have some type of intraoperative imaging, either an O-arm CT or a fluoro that has capability to convert to CT images, but that's changing. So like with the Globus robot, the registration very soon will be able to be done with a preoperative CT scan that can be matched to several fluoro shots in the operating room, which will really cut down on the time necessary to obtain the registration. So that's something that's coming down the line. A lot of people that are rather critics of the technology, you know, don't like the bulky headset. It's going to be basically glasses. I have a picture of that. They're adding digital loops, headlights to it. So it is going to evolve into a you know, a better product. Right now, I think it's one of the big advantages is the fact that you don't have to look away to a remote computer screen. It's more intuitive to be able to look at your patient while you have the heads-up display. it's kind of like the cars when you're driving, you got the speed limit sitting right there where you're looking at the road. That's the analogy I would make. The vendor agnostic thing is a little bit of a double-edged sword, as I mentioned. It's nice because any surgeon can use any of the instrumentation that they would like to use. The downside is that there are some things that I think robotics can do and things that this technology really needs to start doing that we can't really do as well yet. For example, navigating interbodies and things like that, where I think it really helps to know, okay, for the globus or invasive X-lift, how long is that instrument and how long is that cage, so we can actually navigate that cage while it's being put in. And so I think eventually the agnostic thing is going to go away, and the company will probably line up with a single vendor, but that's also going to be beneficial to do some maneuvers other than just place pedicle screws. Interestingly, from a cost perspective, I think it is feasible. I understand you guys just bought a Globus robot. I don't know what your purchase price was, but a lot of times that range is, at least the capital cost is fairly steep, in the order of $1 million. For this, it's a lot less. You can get a few headsets, I think 3 headsets or so, for maybe $150,000, $160,000. There is a per case cost for both. That's fairly similar. So far, if you look
Sorry, can you go back?
Yeah.
So that is the cost per case,
Per case.
$120,000.
Well, I think that cost per case is the entire case for, let's say, doing a lumbar fusion. I don't think it is only the robotic or the.
It includes the hardware.
Includes the hardware. Yeah, this was a study done.
What do you think the incremental cost is of just the device?
Yeah, the device, the incremental. I think it's along the lines of $1,500 to $2,000 for the disposables that they use for the device. Yeah.
So what are the disposables for an AR?
Well, so like the registration markers, they make all that disposable so that they can make some money off it. Yep. So there are about 60 institutions that have adopted this technology. There have been over 5,000 cases done in the US. We've done at least 200. This is sort of what the future may look like in terms of the headset itself. It's going to be wearing glasses, which is going to be nicer. And then what are the other things that need to be done? Well, just like with robotics, again, if you talk to people probably like John Quinn, he's going to tell you putting pedicle screws in is the easiest part of the case I do. I mean, I'm spending more time with the osteotomy and trying to get, the patient's spine in alignment. And so we have to kind of branch out and be able to figure out ways to do osteotomy cuts and perhaps even do decompressions better or navigate interbody devices. So there are probably other things that need to be done to really, I think, justify the technology, because at the end of the day, there are lots of ways to put in pedicle screws. So the tech has to improve. It has to move forward. I really think this would be an interesting way to do cranial surgery. I don't do much cranial surgery. I don't do any cranial surgery anymore. But I think it could potentially be a nice way to do certain cranial cases, because I just think having the headset while you're operating is more efficient than having to kind of like, from what I remember, you get your little chicken foot. You're like, okay, I got to look over here at there is brain shift. And so some of the navigation does collapse at some point, but I think it may be an actual favorable indication for it. And there are some companies that are moving in that direction. The company Augmented doesn't have the bandwidth to add a cranial platform yet, but that would be something for them in the future. So just to finish up, You know, these things get done with a team. I've certainly been very fortunate to have great colleagues, residents, fellows. You know, I do think there is a place for working with industry on some of the new things that we're going to develop in neurosurgery to move the field forward. And that's also been sort of a educational experience for me as well. This is my home team. It's always good to have a home team. I've got Ben is 24. He's a mechanical engineer, works for a consulting firm in Baltimore. Andrew is studying economics at Denison University. And then Teddy here is 11 months now, and he's just kind of enjoying life. This was part of my redo, and this is Meg and I at one of our resident dinners. And incidentally, Meg had a job offer here in Houston. She's a meteorologist and news anchor, had an offer at the Fox station a couple years back. But you know, I wasn't mobile at the time. So yeah, that's it. Open question.
Glad you can.
Getting over the call. Yeah.
CPR. Open for questions. Joe.
So, I've always looked at the AR stuff whenever it was pitched to me as an extension of primarily navigation. Basically, it is a better and more ergonomic user interface for, you know, basically looking at it and then putting your screws without having to look at another screen or something like that. But there is, you know, there is the cost of adoption. This is a really, really fast moving technology, obviously. And hopefully, you know, within the next 2 or 3 years, you're going to see everything kind of shrink down. So it's just glasses. Why should someone adopt the technology now?
Yeah, so I think that, well, now meaning why not wait? Is that?
Yeah, why not wait for another 3 or 4 years before this thing kind of, you know, fully kind of, you know, the landscape clears itself. We have 1 or 2 power players. Everyone kind of has an idea of this is exactly kind of what, and then adopt it then. Why should someone adopt it now?
I mean, I'm not going to argue with your approach. I don't think that that's unreasonable. I think that there are probably, though, some advantages. So like if you look at a standard navigate stealth station, the capital cost for that, my understanding is probably somewhere around $500,000 to get a stealth station, $250,000. So the price point is much less for something like this that, you know, is going to get better in the future. And so I think that would be one argument is I think it's going to be able to do a little more than the standard, you know, kind of navigation system. I'm not saying better in terms of accuracy, although, you know, the line of sight interruption can be annoying with some of the navigation systems. So I think price point is one of the things that might push you to consider doing it sooner rather than later.
From a workflow standpoint, how does the interaction between a surgeon and an assistant work? Do they work simultaneously on different in different areas and have this, or is it the view that the primary surgeon kind of visualized by both?
Both. It's visualized by both.
So you can't work independently with different people on different regions.
Yeah. So basically, you can have 2 headsets active at the same time.
They're all focused at the same.
Usually focused on that point. But then there's actually a navigation screen. So if I wanted to, I could use this as a navigation system also without a headset. I would just have to look at the screen. And so everybody in the room can also see what the surgeon's doing. You know, the workflow is always an issue. And so for people that do freehand, you know, even nowadays, I think many of them are very reluctant to adopt a new technology, whether that's robotics, standard navigation, or augmented reality. The main reason is the first thing that's going to happen is it's going to slow them down. And just like everything else, there is a learning curve with the workflow. And one of the things that's going to actually improve the workflow quite a bit is this concept of CT to fluoro registration. And to Joe's point, another reason to potentially consider it now is once this device gets the CT to fluoro registration, it's going to open up the outpatient, the ASCs in a way that I think is going to be different than just having standard navigation, because now, again, people aren't going to, I don't think a lot of people are going to buy a robot for an ASC. It's going to be pretty expensive. Same thing with, let's say they're going to put a stealth station in an ASC, and if the price point on that is, $250,000 to $500,000, they may be reluctant to do that. And so at least I think the company thinks that from a marketing standpoint, when they get the registration of a pre-op CT to fluoro, they're going to be able to do a lot more in the outpatient setting for MIST lifts and things like that.
I'm going to go out on a limb a little bit, maybe. I think the problem here is not the technology, it's the human. And, if you think about the global, data set here, you have rigid bones. You want to put screws in the bones. The machine can tell you exactly where the screws have to go, but it's the human understanding what the machine is trying to say. Right? And I think, maybe the real answer is the human, the less important portion. And that if there were, yes, I realize it's regulation, 20,000 steps, but a robot did this very well. If things were rigid and not mobile, it could do it very well. Now, obviously, we'll all argue that, whether pediculism or mammillary tuberculosis and all that kind of stuff, and I use that to guide my placement. And there's more information that comes in. That's only a small matter of learning for machines. So with the parallel evolution of AR, I would imagine that unless we really hold it back, robotic evolution is probably going to dominate what happens in a decade.
Yeah, I guess we'll see. I think your point is well taken. I don't disagree with the point. I do think, for example, I've seen cases, I'm very grateful to my partner, Nick Theodore, who developed the Globus Excelsius robot, and yet has allowed me to bring this technology in and work with it. But I can tell you that, Nick has a certain type of intuitive skill, if you will, in working with the robot. He knows when the robot's off, but there are people that don't. And the robot can be off. We've seen cases where, not necessarily our own, where you have a small shift in that registration marker, or something gets shifted, and you've got one screw in the canal and one screw, 3 centimeters outside of the pedicle. And there's some people that don't know that because they've never spent the time to place pedicle screws. And so for me, at least right now, and you may be right, in 10 years, the robots may be so good in the AI, they make us obsolete. But right now, I feel like I love having the tactile feedback when I'm using the AR and I'm actually putting the screw in. I know, I can tell if it's going in the right place or not. And sometimes it doesn't because of skiving, which happens with any of these systems. You can skive the bone and the camera will show you that, the robotic arm is very strong. It'll just push the bone out of the way and it looks like it's going right in the pedicle on the image, but it's not. And somebody like Nick Theodore can figure that out. Some people can't. So it's a well taken point, and we'll see where it goes.
Well, there's also no feedback right now. There's no haptic feedback in robots, which
That's right. That's what I'm talking about.
That's a small step away. There are, we are going to be the Luddites fighting this war. And I think in 20 years, it's gonna be a different story. Orthopedics and spine surgery especially, because it's rigid bodies.
Do any of the platforms have planning software that you can integrate ahead of time and merge?
Well, that's a great question, and that's on the list. I don't know if any of the other ones do. I don't think so, because a lot of times what the planning software requires is having a single vendor and having their, single screws to be able to plan. But you're right, no, we don't yet, and that is a disadvantage. That's another area that they're working on. But I think having it lined up with a single vendor, it helps to do the planning. And that's why the Mazor and the Celsius robots can do it.
Outside of screw placement, I think that's where it would be of most benefit for especially complicated stuff.
Yeah, for big stuff, you want to see where everything's lining up.
Can you tell us, you have a biomechanics lab, and actually here, John, I don't know if you started working with our orthopedic colleagues. We have a lab as well. What kind of work is going on these days in labs regarding biomechanics? What are the hot topics to understand? Is it mostly fusion or stability?
So yeah, I'm not doing much in biomechanics, but I have a spinal fusion and bone biology lab, and I partner with a couple of the biomedical engineers, Hopkins, and a couple of the projects that we do. We've developed a novel bone graft. Actually, one of my MD PhD students developed that has organic components with collagen from small intestinal submucosa, combining that with a inorganic product, so essentially like coral beta tricalcium phosphate. But he designed it in such a way that it's mixed at a room temperature, and now we can add any kind of bone growth factor that we want. So we published a paper. His PhD thesis was on the delivery of BMP. So I think most of you probably know that putting BMP on a collagen sponge is an extremely inefficient way to place BMP. Now, Medtronic has spent a ton of money on patent rights and patent infringements, and they've actually, this was something that was eye-opening to me, they actually filed blocking patents so that people can't develop better ways to deliver BMP. But at least from an academic standpoint, we've been able to show with this bone graft that we've developed that we can basically reduce the concentration of BMP necessary by 10-fold and still obtain the same results. So that's one of our projects. And the other kind of exciting part about that is we can load antibiotics in that bone graft. And rather than BMP, we're going to look at some other molecules. Or PDGF is also a candidate molecule. And then in working with one of our biomedical engineers, we have a 3D printed scaffold that is basically serves as the osteoconductive part of a bone graft. And we can also load bone growth factors on this scaffold and can also combine it with the use of, we're looking at adipose-derived stem cells to enhance fusion through this tissue engineering approach. So there are a couple of different bone grafts that we're working on.
Great. If there are no more questions, why don't we have a 3 or 4 minute break before the neuroradiology teaching session. Thanks, Tim, very much.
Thank you.